Welcome to Spotlight on Seniors, a program focusing on people and issues impacting on the lives of older Americans residing in Broward County. I'm Edith Letterberg, the Executive Director of the Area Agency on Aging of Broward County, and today we're quite fortunate to have a wonderful physician, Dr. Pamela Sutton, be our special guest. Welcome to Spotlight on Seniors, Dr. Sutton.
Thank you. Wonderful to be here.
We always spend the first part of the program introducing our guest to our viewing audience and finding out something about their background, where you were born, grew up, and how you became interested in medicine. So just give us a brief bio of Dr. Pamela Sutton.
Being brief is not one of my strong points, but actually I was born in New York City. I'm beginning to think everybody in South Florida has a connection to New York somewhere. But I was raised in Corning, New York, which is upstate, and then in Southern California. I got interested in medicine at a very young age. My mother...
Wait a minute, how'd you end up in California?
Well, my father got a job in California. He is a physicist. He worked for the Corning Glass Works doing optics with glass. And those of you who follow the stock market know that Corning ended up being a big player in the optical market all these years later. But he was then hired by Ford. Well, it's a long story, but there was an aerospace industry in California that was hiring physicists, and he got moved there.
Oh. So a lot of us are from New York, but I'm from Long Island, and of course I know Corning, and I know the fiber optics were the big thing with Corning.
Right.
They're not doing too well now.
No, well, that'll all change.
But that's another kind of story.
Right.
So you actually went to school for the most part in California.
Right. From 6th grade on, I was a Californian. And I got interested in medicine I remember it in my adolescence. My mother says it started earlier. In any case, I actually got interested in medicine because of reading Albert Schweitzer books, and this sounds so corny, but it's the absolute truth. I read some of those books and thought, oh, it'd be so nice to be helpful to people. And I got really focused on being a doctor, and I worked really hard to make it happen.
See, being a physician, as far as I'm concerned, is a calling, almost like the ministry is a calling. Mm-hmm. You either want to be one or you don't, and I think too many people go into it just for the idea of the money that's involved, but to get someone who's caring and wants to be a physician, that's a bonus to the world. Well, tell us about your schooling. You went to school in California.
I went to college at Pomona College in Southern California, little liberal arts school, which got people into medical school, which mattered. It was the Vietnam War era. Every boy wanted to be a doctor because they were being drafted, and the competition to get into medical school was fierce. Women weren't doctors anyway, for those of you who remember those battle days. So it was definitely, I mean, it was a very focused, intentional thing that I did to go to Pomona College because they got their graduates into medical school very consistently. And I went to the University of California in San Francisco for medical school.
My daughter, with the Vietnam, with the veterans and whatever, she was in the top percentile of her class, I mean, way up. And they were only taking people into the colleges who lived in particular states. Mm-hmm. And she ended up at my old school, which was the University of Vermont, which is not a state university, even though you think it might be. Mm-hmm. But so you went to college there, and then you went to med school there too.
I went to med school in San Francisco, University of California. It was 1969. That was the year we went into Cambodia. San Francisco was a wonderful, wild, woolly place to go to school. The school shut down. It was a memorable 4 years, that's all I can say. I did well, and
You certainly did. You graduated magna cum laude, and you...
That was college. But I was rather astonished, actually. They had an award at the University of California called the Gold-Headed Cane, which was given for the students that the faculty and students thought would exemplify the art of medicine. It wasn't the highest grade point average. It was the art of medicine, and I was very honored. They actually awarded me with this honor.
You must have deserved it. What type of medicine? You don't specialize in med school. It's afterwards.
No, you
correct?
go into an internship residency program after that, and I decided to go into family practice, which, strangely enough, was a new specialty then. I mean, we laugh at that because everybody had general internships in the past, and they had these general practitioners, but this was the beginning of 3-year residencies for people who wanted to do family practice. So I went to Rochester, New York, to one of the premier family practice programs. I guess I had to go back to upstate New York.
And you wanted to get back to
I needed to go back to my beginning.
Go back to the snows.
Just back to the snow, right?
Yeah.
And
I know my nephew's a physician, and when he did his internship, well, that was in the late 70s. He spent, was it 6 weeks at 3 different medical institutions. They didn't spend a long time anywhere. They just went around and
they rotated.
And then he ended up, because he owed money to the government for paying for his med school, he ended up in West Virginia for a couple of years.
Is that right?
Yeah.
Yeah, there was a National Service Corps. There probably still is for people who have some government support to pay it back when they finish.
Right, so they don't have all the loans or whatever to take care of. But your background is really interesting, because when I looked at it, you went to many places all over the world. Did you do that right after med school, or?
Well, actually, I finished my family practice residency, and then I went to England. Well, I did a lot of things, it's true. I worked in North Carolina and Appalachia for about 5 or 6 weeks with 3 very rural clinics, being a general... Very poor area, supervising nurse practitioners who were really the doctors in that Appalachian area. And then I went to England and studied tropical medicine for 5 months and got a diploma from the University of London. That was a wonderful experience, and because remembering that I got stimulated by the Albert Schweitzer books, I had this idea that I was going to go overseas and disappear into the jungle somewhere. But I got very discouraged when I was in England, because the old professors there, who were expert overseas, you know, they had lived in Africa for years. They said, you'll see 200 patients a day. And that just boggled my mind. I thought of Albert Schweitzer somehow stupidly holding somebody's hand, you know.
You ended up in Kenya, right?
Well, no, that's an even longer story. I mean, what happened ultimately, as I got discouraged, I came back to Boston. I spent a year at MIT studying nutrition. They had a program for physicians. I was already a board-certified family practitioner. I went through my second adolescence, I think, trying to figure out what to do with all my education, because I couldn't quite figure out how to plug in overseas.
You're the perennial student, but meanwhile you were learning all these different medical techniques at the same time.
That's right. Well, so then I heard about hospice. And this is an irony, because I had been in England for 5 months, and I didn't know about hospice, and it was all right around me probably, but I was studying tropical medicine. It was 1978. Hospice was a new idea in the United States. Not new in England, but coming. And I decided that that was something I could relate to. One of my issues was that the pressure in our high-tech United States medical care was volume, volume, volume. You had to hurry up, see lots of patients. The business managers didn't like me very much, because that wasn't my instinctive style.
Even then, and yet I still remember.
Even then.
But it's amazing, because what I remember and treasure were the memories of the physician coming to my home, sitting down, having a cup of coffee, actually playing with my children,
right,
and spending an hour. We built tremendous relationships. Now, if you're lucky, the doctor knows your name without looking at the chart, and hopefully the chart is the right chart.
Yes.
So I think we've lost so much, and of course, the late 70s, that was still before the HMOs had become a reality. So the pattern was set, and it just became worse and worse and worse.
The pressure became greater and greater, and I knew at that point that it was already not for me. But when I heard about hospice, I thought, I can relate to that. And one of the reasons I could relate to it is I recognized that I and the doctors around me in our training program didn't do a very good job taking care of dying people.
They didn't want to work. And
we didn't know what to do, really.
Well, a lot of the dying people are elderly, too, and they didn't want to deal with the elderly because they wanted to deal with the pediatricians. The people who became pediatricians wanted to deal with children. Then you have the people the obstetricians who wanted to deal with women and bringing children into the world. But there has always been a tremendous amount of negativity on the part of physicians to become a geriatric specialist, and that would tie in with the hospice concept, because you're dealing with people whom you know don't have a long time to stay on this earth. And I think physicians, like other people, they want to see something where the progress will be noted by someone walking out of the hospital cured or recovered. And that isn't what hospice suggests. And I think that's why a lot of reason why some physicians just don't want to be bothered.
Well, I can tell you that training from 69 to 73, and then 73 to 76 when I did my residency, the whole issue of death and dying or serious end-stage illness, that whole subject was never addressed in that manner.
Until Elizabeth Kubler-Ross
right.
came on
Elizabeth
the scene, and we were all
Kubler-Ross
fascinated.
woke everybody up and said, "Did you know you really have dying people in your hospitals?" That was a revelation.
Well, how about the fact that she woke people up to the fact that they were going to die someday, and their relatives were going to die as well? That was her name was the big buzzword in social services in the late 70s and early 80s, and everybody got the book Death or Dying, and if you could get any semblance of her to come speak somewhere, this was the greatest thing that ever occurred.
Sure.
But this was the amazing mystery of the century, you know, of all centuries. People are going to die no matter what you do to try to save them.
Well, that's right, and that's the interesting riddle in what's happened in medical care. I mean, the Western societies adopted a cure model. I mean, why do we go to the doctor? We go to the doctor most of the time because we want to be well. And that model works fine if a healthy kid gets a strep throat. You take them to the doctor. You don't talk a whole lot of philosophy about anything. You get an antibiotic that's specific to the strep throat, and the person is well. But what's different in our society is people live long, and we actually get sick and die from from chronic illness. Long, gradual, progressive chronic illness. We live to be old, thank goodness. And that changes the whole model, because the model of cure is not totally applicable to that.
I think the pendulum has swung beyond that even, because people are living much longer. You know, when I first went to work for the area agency in the late 70s, if somebody lived to be 65, that was fairly old. I lost my grandfather when he was 59. My dad passed away when he was 62. The women have longevity in my family, so that's a healthy sign, we hope. But living to be old had a tremendously different connotation from what it has become. You know, nowadays, unless someone who's 100 years old has been married 5 times and is dancing out in the streets and looking for the next husband or wife, the media doesn't even cover the event. But back in the late 70s, we had a few people who got to be 100. It was a major thing in everyone's life. And I think that's all part of it as well. You know, now you've got this entire new group of people who are living older, and you don't have physicians who are that old themselves that they can relate to what a person is experiencing.
That's true.
Explain an arthritic pain that a senior has and be talking to a physician who's 45 years old. He doesn't have a clue, and he doesn't want to have a clue.
He doesn't want to take the time. He's got too many people waiting. And the HMO wants him to move.
Well, that's just it.
That's the basic problem.
So when did the HMOs really came in the early 80s? I believe that's when they really started springing up.
Right, they started remanaging medical care.
Right, we had someone who worked in conjunction with the area agency at that time who came to me and said he's got a novel concept, and he and this other gentleman are bringing it to South Florida for the first time, and it was the HMO concept. They said it's going to be great for everybody. The amount of money they're going to have to pay is very little. They're going to get very fine medical care. And the first thing I said was, and they're going to lose having a family doctor who even knows their name. And it wasn't that I was so brilliant. That is exactly what occurred.
Yes.
And you obviously weren't fascinated. You really wanted to work with people on a continuum and try to help them.
Yes. Live
their lives as long as they possibly could, with someone who had a sympathetic ear and a helping hand to do that. And that's something for which you should be very commended. You know, before we have the break in our program, just tell me a little bit about all these other countries you went to visit, because looking at your resume is extremely fascinating.
I got interested in hospice. I moved here in 1978 to help start a hospice program. That's basically what happened. And then in 1985, 84, Christmas 84, you may remember there was a horrible famine in Ethiopia. And I thought, well, you know, if I'm ever going to do this overseas thing, I have this tropical medicine training, now ought to be it. So I went to Ethiopia for 3.5 months, worked in a feeding center. And then I came back to the area and started taking care of hospice patients again. And at that point, we had an AIDS epidemic. I took care of a lot of AIDS patients at home. And then I went to Pakistan, to Peshawar, which has been on the news since 9/11. There was a big Afghan war, and you know, the United States was there supporting the Afghan Mujahideen against the Russians, and I was involved with training paramedics in Pakistan.
You were training people.
Training paramedics, right.
So that's a far cry from the famine that you were dealing with.
Exactly. Well, it was really more of a family practice kind of role, which truthfully didn't suit me very well, but it was a teaching role, and I helped to edit a training manual. We actually worked on a Macintosh computer, and the lights kept going out.
With you, everything I see is challenge, 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 or you're not satisfied with anything. I mean, when you finally, and maybe you've already done it, write a book about your experiences, nobody is going to believe what you put in the books, because in looking at your resume, I mean, there are about 14 different countries that you went to, and there's not much explanation as to, but I just see this tremendous thirst for more knowledge and for helping people, which is...
I love the international community, too. That's why I just keep making excuses to go back home. But what I did finally is after that Pakistan experience, I went to the World Health Organization in Geneva and asked to do palliative care, which is hospice-type work, overseas. And ultimately, I did it in India, and then came to East Africa on the way home from that trip.
Teresa?
I did not meet Mother Teresa. She was in Calcutta, and she was in Eastern India. I was in Western India.
And never the twain will meet.
Never the twain met, right.
Well, we'll be back with our special guest, Dr. Pamela Sutton, in just a very few moments, and we'll find out what she's into today. Heaven only knows where she'll be tomorrow.
At age 70, Edith Letterbird chooses to make the most of each and every day.
I had never been on a motorcycle before in my life, and it shows the sense of adventure is still in my heart and soul.
For more information on how you can live life to the fullest, call the Florida Department of Elder Affairs.
Welcome back to Spotlight on Seniors. Today's special guest is Dr. Pamela Sutton. We're hearing a lot about palliative care, and we know you're involved with the Barbara Ziegler Palliative Care Centers. We have one at Broward General Hospital, one at North Broward. Talk to us a little bit, first of all, how they finally got you to stay still long enough to be affiliated with one particular hospital, the North Broward Hospital District.
Well, actually what happened is after my wanderings and working for the World Health Organization to do palliative care in India and East Africa, I came back to the United States and I adopted some children who were born in Broward General. And they're currently 14 years old, they're twins. And therefore I am rooted at the moment. And so starting in 1994, I became an employee of the North Broward Hospital District to promote palliative care. Now, you're saying, what is palliative care?
Yeah,
right?
Define it
you know,
for us.
I mean, even the hospital district wasn't sure what they had hired, I think, because it was a new concept for most people, and still it's not well understood. To palliate means to make comfortable without curing. Now, going back to what we were saying before, that's sort of paradoxical in our medical care system. What we all want from our doctors is to be cured, right? But the reality is, for all of us as we age, that we end up with some chronic conditions, and many of them need pain and symptom management, as well as whatever curative things are out there. But what happens for most people when they go to the doctor, they know there's a time pressure, and especially with cancer, and I know this happens all the time, the cancer patient thinks, well, I've got to get my questions all lined up, right? You know, because the doctor's going to come in and go, boo, 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 and go out again, right? So you say, you ask cure questions, not care questions.
Well, that's because people want to believe that they're going to be cured.
Well, sure, everybody wants to be cured, and we aren't negating that. But what palliative care says is, you deserve to have pain and symptom management.
Right, because death is inevitable.
As well as whatever else the medical care system.
Death is inevitable for all of us, and it just comes at particular time, different times in people's lives. But the whole thing of the palliative, isn't it, to make people as comfortable as possible.
Absolutely.
And get them through all the stages, you know, the denial and the grief and the anger and all the things of...
Like there's a lot of pain in it.
But the type, oh yeah, but the type of staff you have to do that, and you yourself, I mean, you have to be so caring and not get yourself personally involved with each patient. I mean, that, when you're seeing a little child and they come in for their regular checkup and then you give them a lollipop or whatever it is you give them when they say goodbye, that's great for the pediatrician. With the type of care that you're providing, you know that, especially with most of the people, it's not as fast and as hospice might incur. But you know that they're on their way, that most of them are not going to recover. They may recover enough to leave the hospital for a time, certain period, but you know they're going to be back. And that's tough. That's tough to deal with a family as well. Do you get referrals from other physicians?
Well, yes. I mean, I think perhaps, if you wouldn't mind, I think I should clarify for your audience why palliative care is different from hospice. As you probably know, hospice takes care of a person who is estimated to have a prognosis of 6 months or less. Now, they may be wrong. Doctors have to guess, basically, and people outlive their 6 months prognosis, and the hospice will hang around still, provided they are truly ill. And then sometimes they discharge people because it was totally wrong. But what palliative care says is nobody should have to hang a prognosis on you. Nobody should have to limit your treatment options. You should still be able to get pain and symptom management by a team, doctors, nurses, social workers, a chaplain, volunteers, whatever you might need to supplement your care in our palliative care units in the hospital.
Where does Barbara Ziegler fit into this? Because I know the Palliative Care Center is named after Barbara Ziegler.
Well, Barbara Ziegler was a lovely lady who lived in New York City. She had cancer. She was my godmother. So this is a direct reflection of the fact that I really believe in palliative care. When she died, she named me as the advisor to her charitable estate. She had a lot of money. I had a connection to Memorial Sloan Kettering's palliative care program. I had,
in New York, right?
In New York City, where she lived. And most of that money went to the palliative care program at Memorial Sloan Kettering. And just for your information, they come every year. The palliative care team from there comes every year and educates our medical professionals in South Florida about palliative care. We have a relationship with them, the North Broward Hospital District. Barbara Ziegler Palliative Care Program here has a relationship with the Barbara Ziegler Palliative Care Program at Sloan.
That's strictly through you. I mean,
well, it's because I made the connection. I connected the North Broward Hospital District to Memorial Sloan Kettering via the palliative care programs.
Right.
Because some of the funding came for our palliative care program also came from Barbara Ziegler's estate. And what we're trying to do is bring this pain and symptom management and emotional support to people who, for whatever reason, do not want to be in a hospice program, aren't really eligible for a hospice program, but have these life-threatening or serious illnesses.
Well, because the picture that has been painted of hospice is exactly what you said before. You've got 6 months maybe to live, and people don't want to admit to that. How do people get into this program, and, you know, is it covered by insurance?
Well, at present, the word palliative refers to something in the regular medical care community and regular insurance. And this is both a problem and a plus, I suppose. We are not restricted to hospice rules, which means you can have any kind of a prognosis, and you don't have to give up anything. But if you're going to be in the hospital, you're under your regular Medicare or Medicaid or Blue Cross Blue Shield, regular insurance.
But is it covered?
It's a free service, basically. And we are providing nurses to supplement your regular hospital care from the Barbara Ziegler funds. We're paying them from the interest from our endowment.
So part of the payment would come from your insurance, and then if there weren't enough, it would be subsidized.
Right.
Talk a little bit about the new equipment. Some of us serve on this Cancer Advisory Council for the North Broward, for its combination actually as Broward General and North Broward, that has very specialized equipment to treat cancer. Mm-hmm. And I know that ties into what you're doing as well. Okay, you want to just talk for a minute or so about that? I know that we're trying to raise money for that particular purpose, and we did see that when we toured the North Broward Medical Center.
I believe you're referring to the radiation therapy programs.
Exactly,
both North Broward Medical Center and Broward General have machines that are very effective against cancers, and they give radiation therapy. And you may never have thought of it quite like this, but most radiation therapy is actually palliative. It's not actually curative. Most people who receive radiation therapy for cancers are receiving it for pain in their bones. And not always, and I don't want to scare you all out there. I mean, there are some people who are actually cured with these treatments depending, and for example, early breast cancer, they frequently will radiate the chest wall, and many of those women are cured depending on how early the stage was. But for many people, radiation is palliative. A lot of medical care for chronic serious illnesses is actually palliative. It's really made to help the patient feel better without actually curing them.
Well, with some people, though, I thought that the new equipment, it concentrates on a smaller area without having to zap the entire body with radiation.
Right.
And that in itself would be palliative.
Of course, it's a better way to do it with less side effects.
Right. And you have, so the patients, they can either stay at the hospital or stay for a time certain and then be released and then come back. Is that how you do this? Or do most of them come and stay?
No, you are referred to our palliative care program by your doctor, who will probably think of it when you're in the hospital with a serious condition which requires pain and symptom management or emotional support. And when you go home, if you would ordinarily be appropriate under your insurance for home health services, visiting nurse services, you can have a palliative nurse come from Gold Coast, the Gold Coast Palliative Care,
with the North Broward Hospital
which is affiliated with the Palliative Care Program, as part of the North Broward Hospital District. So we see people at home, we see people in the hospital at North Broward and at Broward General, and I have some patients who see me in the cancer centers in both hospitals.
You kind of go all over
it,
and you go to the homes too, don't you? When you
yes, I sometimes go to the homes.
I would imagine you'd be doing it all. You'd be in the hospital, you'd be in the homes.
I have always done a lot of that. I'm now working with a wonderful doctor named Shirley Kodada, who's a well-known internist in the area and who is working to do palliative care to expand our program both inpatient and home.
Well, then you can team up with, just quickly, do you have a telephone number you want to share in case people want more information about it?
Yes, if you wish information, call 954-355-5423. I think it's on the back of this brochure.
Yes, it is. But just say it one more time because we're going to have to close.
Make sure that I have the right number.
Oh, I'm sorry.
I think it's in the back.
There you go.
Yes, 355-5423.
Right.
954-355-5423. That's for the Barbara Ziegler Palliative Care Program.
Right. And when as the curtain closes, I'm sorry, on Spotlight on Seniors today, we want to thank you for being with us and sharing some very interesting data relative to palliative care. The spotlight dims on today's program. We want to thank our special guest, Dr. Pamela Sutton, for being with us, and remind our viewers that aging is one of the most priceless gifts presented to each of us by God. It is wrapped in life's most precious moments and perpetuated by caring, sharing, dedication, and love. In your case, Doctor, lots of love. Thank you for being here.
Thank you.